morning. My name is Dr. Eleftheriou, Perla Eleftheriou, and I'm a hematology consultant at University College Hospital in London in the UK. And thank you very much for inviting me to talk at this conference. I really truly wish that the next one would be a non-virtual one and face-to-face to meet everyone involved. So I have been asked to talk to you about the impact of COVID-19 on patients with hemoglobinopathies in the UK. And this is a talk prepared by myself and my colleagues, and I'm sharing this data with you on behalf of the National Hemoglobinopathy Panel of the UK. So around 15,000 people with sickle cell disease and 2,000 people with thalassemia live in the UK based on the data of our National Hemoglobinopathy Registry. And as you can see on the map, the majority of our patients are in the London and in the Midlands area. During 2019, NHS England undertook a major review of the specialist provision for patients with hemoglobinopathies, leading to the procurement of 14 hemoglobinopathy coordinating centres for sickle cell disease and thalassemia across England, and the formal designation of specialist hemoglobinopathy teams, all overseen by the National Hemoglobinopathy Panel, which consists of several experts in this field of hematology. With the help of the next few slides, I will talk to you through our work and data collected so far in the UK since the pandemic started at the beginning of 2020. I'll first give you an overview of the program we implemented for this data collection and then present the data so far, broken down looking at how each hemoglobinopathy cohort was affected and outcomes on transfusion, hospitalization and mortality, as well as a summary of the experience collected so far from other countries. So please note that in these slides, the demarcation of the first and second wave of the COVID-19 pandemic, as well as the third, are as follows. The first wave from February 2020 to the end of August 2020, the second wave from beginning of September 2020 to the 31st of May, and the third wave from beginning of June 2020 to current date. So early on in March 2020, through regular multiple virtual meetings and calls, the 32 hemoglobinopathy centres across England and Wales came together, created a national data platform, which was shared by all centres, and data was submitted weekly by the 14 leading hemoglobinopathy coordinating centres. This was in very close collaboration with the National Hemoglobinopathy Registry that we have in the UK, and the actual data collection started on the 6th of April 2020, and results were presented indeed nationally and internationally at various platforms at various points in time, as they were updated in real time, such as the EHA, EuroBloodNet, ASH, and also published at journals such as Hematology. So this is a slide showing the cumulative cases rising in the UK from the start of the data collection in April 2020 until October 2020, reaching nearly 900 cases of patients with hemoglobinopathies and COVID in the UK in total. So on the right side now of this slide, so where you can see the table, which summarizes the cases across all the hemoglobinopathy centres. So you can see that all the areas of England have been affected, but the number of cases per hemoglobinopathy centre really represents the proportion of patients treated at the different hemoglobinopathy centres across the UK, with very high cases of COVID positive patients seen, especially in London and especially in the east parts of London, as well as the Midlands. So here, here you can see the breakdown of the different phenotypes of hemoglobinopathies that have been affected by COVID. And it is very obvious that the majority of the COVID-19 positive cases have been hemoglobin SS patients, so the 67% of the total cohort, followed by the hemoglobin SC sickle cell patients, which is a 16% of our cohort, and patients with thalassemia syndromes follow. The majority of those with the beta thalassemia major affected more than those with the non-transfusion dependent thalassemia patients and the hemoglobin H disease patients. So this mirrors really the national demographic picture as per National Hemoglobinopathy Registry, as you can see on the left. So if we go on now to look at what treatments these patients required during these 3 waves collectively, in terms of hospital admissions, pretty much half were treated in the hospital and managed at home, with slight predominance of management at home without the need to receive hospital treatment. These 3 pies show you that the proportion of patients admitted in the hospital during the first wave was significantly higher than those admitted in the second and third waves. And we believe the advice and guidance from the hemoglobinopathy experts, with the help of this data collected throughout, and which fed into the recommendations which we had been giving to the authorities as to how to shield and protect these vulnerable patients, contributed to the reduced hospitalizations seen later on in the second and third waves. The COVID immunization was introduced in the UK in late 2020, December 2020, and this is when the majority of our patients would have received their first dose, followed by the second one in the first 2-3 months of 2021. And this could also be one of the reasons for what we observe here. The proportion of hospitalization seen in the third wave is similar to the second wave, but the total numbers during the third wave are lower, and this is probably because the period of time we covered in the second wave is longer than in the third wave. In terms of respiratory support for hospital admitted adult patients, 10% needed NIV support and 6% intubation. In regards to transfusion requirements, specifically in sickle cell disease patients, the majority of the patients did not need additional emergency transfusion, especially because of their COVID illness, and this applied to both the children and the adult population. About 1/3 of the adult sickle cell patients needed emergency red cell exchanges, and 25% of the children needed emergency top-up transfusions. So, looking at the age and gender of the patients, you can see that the majority of the patients affected are young and between the ages of 20 to 39, followed by 50 and 60 years of age, and really much fewer children and teenagers were affected. A possible explanation for this is that schools closed early on in the UK, therefore the children's movements outside their household and mixing with others were restricted. And the age group affected represents the working cohort, of whom many could not work from home and had to go out to do so, as well as those at the age where lifestyle can be more sociable than in other groups. The female to male proportion was almost the same, with slight predominance of the female gender. In relation to the mortality until June 2021, so waves 1 and 2, 6% of the total adult hemoglobinopathy COVID cohort sadly died, and thankfully all children survived. In those who died, the mean age was 50 years of age, and the mean age of those hospitalized was 29.6 years. Looking closer now at the impact of the third recent wave, 160 new cases were recorded since 2020. And you can see again that the majority of the patients were hemoglobin SS patients, so 63%, followed by the hemoglobin SC patients, so nearly 17%, and followed by the thalassemia patients, of whom predominantly were transfusion-dependent thalassemia patients. From those 160 cases, the majority of the patients recovered, managed and recovered at home. 24 were, of those managed at home, 24 were children and 60 adults. 76 out of those 160 cases were admitted to the hospital, 67 adults and 9 children. And out of those 76 admissions, 10 were still inpatients at the time we analyzed this data recently. And the majority recovered, 63 recovered, and sadly 3 have not survived. So this summarizes the further mortality data now, including the cases reported since June 2021, so the third wave mortality included until now. So we had 30 mortality cases so far from the beginning of the pandemic until now, 12 patients with hemoglobin SS, 8 patients with hemoglobin SC, 6 patients with transfusion-dependent thalassemia, 1 patient with hemoglobin S and another mutation, 1 hemoglobin H, 1 hemoglobin S beta thal, and 1 congenital dyserythropoietic anemia. So this table shows, thankfully, more than 90% of all the patients, regardless of the phenotype or of the type of the hemoglobinopathy they had, completely recovered. Only sickle cell disease patients needed hospitalizations in our cohort. And in terms of the mortality, patients with a severe sickle cell disease phenotype, mortality was 2.2%. Those with a mild sickle phenotype, so predominantly the SC patients, the mortality was 6%, and the mortality in our thalassemia patients was 5.6%, and other rare inherited anemias, 4.3%. Sorry. It is interesting to know that proportionately the milder phenotypes, sickle cell disease phenotypes, such as the SC disease, were more affected from the mortality point of view than the more severe phenotypes. And at the moment, there is no very clear explanation for this, although different theories are sort of hovering around. For example, a lot of those people with SC disease were not on sickle modifying treatments or did not shield as effectively as they should do, as considered themselves low risk due to the milder phenotype. This table shows you closer the thalassemia cases. This is a breakdown essentially of the thalassemia cases affected, and you can see that the majority of the patients affected from the thalassemia cohort were transfusion-dependent thalassemia patients, ages 5 to 67, and the majority recovered fully, and 6 did not survive. So this slide shows you the outcome compared to the general population. This data was compiled May 2020. So general population data in the UK, about 200,000 cases of COVID-19 until then, 14.8% mortality from that cohort, median age for admission to the hospital, 73 years old. And patients with hemoglobinopathies in the UK up until that time, May 2020, 195 cases of COVID-19, included the suspected one, because don't forget that COVID testing had not been introduced until later in 2020. Then 7.7% mortality, and median age for admission, 31 years. And now adjusted for age based on data from our National Hemoglobinopathy Registry and the Open Safely study, which included 17 million people and published in Nature in July 2020, and looked at comorbidities associated with increased risk of COVID illness, clearly shows that the risk for severe COVID illness is significantly raised in patients with sickle cell disease in the young cohort of 18 to 49. So this cohort is much more likely to develop severe illness from COVID compared to the general population and age-matched cohort. In relation to the impact of COVID vaccination, we can see that from the adult ones who needed hospitalization, the majority of those were unvaccinated. Thankfully, thankfully, though, the majority recovered. From those who developed mild COVID illness and managed at home without hospitalization, approximately the same proportion were vaccinated and not vaccinated. And here some evidence from other countries. So the France study published in the Lancet Hematology in September 2020 included 83 patients with ICU, 2% mortality, but all the sickle cell disease patients should be considered vulnerable. That was the American study published in Emerging Infectious Diseases in October 2020 included a higher number of patients, 178 people with sickle cell disease. 69% were hospitalized, so much higher rate of hospitalization and higher rate of mortality of 7% compared to the French study. And of course, these may not be representative of all COVID-19 cases among persons with sickle cell disease, but it does suggest that the high risk for these people, for patients with sickle cell disease, for a severe COVID disease course and a high case fatality rate. So to conclude, a significant number of hemoglobinopathy patients in the UK have developed COVID-19 illness, and many unknowns still remain, and absolute numbers are still statistically relatively small to draw further detailed conclusions. But there are known risk factors for COVID-19 that highlight the vulnerability of this population, such as sickle cell disease patients are primarily of Black origin and are overrepresented in deprived areas where the socioeconomic status is low. Please do continue to encourage all your patients to have the COVID-19 vaccines and reassure them that the benefits outweigh the risks to prevent severe illness, hospitalization, and mortality. And hereby I want to thank you for inviting me to talk to you about the UK experience. And I want to thank all my collaborators, all the UK hemoglobinopathy doctors and nurses and psychologists and everybody who's looking after these patients, as well as most importantly, my patients. Thank you very much.